This is Dr. Brijesh Chandwani. Dr. Chandwani completed his orofacial pain residency at Tufts and is he's an American Board of Orofacial Pain certified orofacial pain specialist. Yeah, you can do that. He's an experienced clinician, author, and speaker on this topic. He's also a licensed acupuncturist and incorporates complementary medicine in his practice. And I've heard him speak before, and he's really engaging, and we're in for a treat. So please welcome Dr. Brijesh Chandwani. All right.
Great, happy to be here. We'll talk a little bit about oral appliances. There's a number of names for this. Some people call it splints, mouth guards, bite splints. No conflicts of interest to disclose, sadly. All right, so we'll talk about oral appliances, how they fit in, some evidence-based perspectives. They're really perspectives. There's really not good data on a lot of what we do, unfortunately. And I'll touch on different oral appliances that I use and make sense of clinical practice. So, I just like how Emily just mentioned, I actually changed a couple of slides. I really look at oral appliances as physical therapy rather than stopping bruxism or really, we don't know how they work, but I strongly feel, just like different physical medicine, oral appliances is one modality where they can really change behaviors, re-educate muscles, re-educate joints. So, and in the last 10, 15 years, there's functional imaging studies which have shown active brain changes when somebody uses oral appliances. Disclaimer, we don't know what it means when it comes to symptoms. If there's brain changes, does it mean that the pain would resolve? No. It just shows that things are changing in real time when somebody uses oral appliances. So, when it comes to temporomandibular disorders, kind of looking at, I always, anytime a patient comes in, I look at kind of top down, kind of you want to look at central nervous system, what's involved, and then go from like bottom up also, peripheral nervous system to going up. Self-care is huge, just like how Emily was saying. I would say about 25-30% of my patients resolve with self-care. They don't go to oral appliances, injections, medicines, but it takes time. I always educate them. I actually haven't heard Rockabada for a really long time, but I tell my patients, just stretch your masseter and temporalis for like 20 seconds, 6 to 8 times a day. I had on Etsy, I had a 3D printed simple gadget which has a scale, and they can use it to prop their jaw open. Cost me $1, and if any of you wanted to kind of use that, just send me an email. You can find my email. I'll share that person's information. It's really a triangular shaped scale, so has measuring 20 millimeters, 25 millimeters, 30 millimeters, so patients can measure it. I give it to patients. I was like, just have passive stretching, allow the device to prop your jaw open. And I'm always surprised. Patient comes in at 20 millimeters. I was like, do this for 10 days and let me know. And 25% of my patients cancel appointments after 10 days. They're like, oh, I'm opening better. But I ask them to do it every hour and a half for like 20 seconds. Not too long, but it's really a powerful tool. Now, anytime somebody improves with something like stretching or oral appliance, doesn't mean that the mechanism was peripheral. So, and we'll talk more about that with injection, kind of I'm lecturing on injections, but treatment response should not be confused with causation. Okay? So how do these mouth guards work? Hal Menchel, Chuck Green, and they had this really good paper where they talk about, are they biobehavioral appliances? Do they alter joint mechanics? Is it a kind of an elegant placebo? I really don't agree on something like an elegant placebo. If it works 60% of the times, it's not placebo. We all know. I'm not a big fan of ultrasound. Emily was saying, is it placebo? I don't think if it works for that patient, you cannot say it's a placebo because it worked for that patient. So there's a couple of researchers around at University of Florida as well as at Mass General. They're looking at placebo response, nocebo response, how to kind of harness some of that effect. But they've also made this point that if its effectiveness in clinical trials is more than 40-50%, it's active medication, because that's how the pills work too. And is it regression to mean? I really think so. I've been at a fault for doing this. More early on in my career, a patient comes in and in acute pain or limited movement, put in an appliance, and he or she uses it for 5 days, and they're better. And I'm like, oh, the appliance really works. Now I'm thinking, no, it was just time. So if it's an acute process, it could be regression to mean. The more complex your patients are, there's going to be more variables, and your treatment has to be kind of altered accordingly. So it's always important to understand what are variables involved in that particular patient. So when you look at evidence-based medicine, they're kind of taking a big pool of patient and generalizing treatment. If you generalize a treatment like stretching, physical therapy, you're not going to get side effects. But if you're generalizing oral appliances, pills, injections, you'll get side effects. And that's a talk by itself. One of these days, I'll do kind of a talk on my kind of bad outcomes. I've had plenty of these over the years. So these are some of the things I have noticed tend to kind of throw a curveball in my kind of treatment paradigm. And being in pain sucks. It's really difficult. Having empathy at times being kind of, I have people who are kind of my family members, and I always tell them, I don't want to treat them because I don't think I'll be objective enough. There's too much emotion. So it's difficult. Okay, this is just, I was looking at Emily's slide. So my treatment paradigm is slightly different than this. So I usually kind of add, right after my diagnosis, I'm kind of thinking of the phenotyping of that patient. So sleep is a big one. And it could be sleep disordered breathing, insomnia. It changes everything. Somebody who has trouble falling asleep, I'm using a muscle relaxant as my go-to rather than oral appliance, even though I think primarily it's a joint problem. If they sleep crummily, I always feel sleep takes precedence. And I don't have data on this, but it's been shown about 70% of patients who have sleep problems, you got to address their sleep concurrently. And I have a little bias because of my practice style. I tend to address sleep more first rather than concurrently, and I give it 2-3 weeks, and I'm always pleasantly surprised. Patients who have different pain conditions, I use 3 modalities to ask about that. Ask them pain anywhere else in the body, what medications are they seeing, and what doctors are they seeing. Always ask those, and that will give you a sense. Patient who has depression, limited opening versus kind of pain. I always find patients who have limited opening tend to get better compared to kind of these non-specific pain syndromes. So what about evidence-based medicine? So I always, again, split it into different conditions. Internal derangement, limited mouth opening is one condition. Muscle pain is a different condition, bruxism. And then this non-specific functional disorder where clearly you cannot figure out, is it this distinct modality or mechanism, or is it really central sensitization, or they have neck pain and now they have secondary or concurrent jaw pain. So most of the evidence, unfortunately, lumps all conditions together. And then, hence the overall data is extremely poor. We have a bunch of meta-analysis looking at short-term and long-term effects. Short-term effects, there's some positivity, but if you look at long-term effects, appliances are really not very effective. Now, they're comparing it to no treatment. And I always tell patients where I'm going through the differential diagnosis, they don't have like a tumor, they don't have a joint problem, like a degenerative joint disorder. I tell them, if you leave it and we meet 5-7 years later, I can almost guarantee you will be better. Now, day-to-day suffering, I don't know. That's what you're treating at times. Across the board, there's data that appliances work short-term really well, but long-term, there's good outcomes with most modalities, just like Emily mentioned. Most treatment modalities have good outcomes. Although if you look at localized muscle pain, localized joint pain, oral appliances tend to seem better than most modalities. Okay, better doesn't mean they're significantly improved. So, okay, and the data for against drug treatments, psychological treatments, the previous slide talked about. This Cochrane database showed that compared to drug treatment, is similar data. They both work okay. Compared to surgery, it's similar too. Now, if you look at, so I picked up a slide from stroke survival with treatment, and DMD is like, if you look at mild problems, no matter what they do get better. And when it's a severe problem, no matter what they get slightly better. Okay, so that's kind of your take-home message. I'll switch gears to kind of practice what you can take to home. So always remember, even if you cannot figure out a distinct pathophysiology mechanism, patient's pain is real. There's more and more data coming out that the physical pain in most of these patients is real. Show empathy before you and show tact. Always give them options as to, this is your diagnosis, this is what the evidence says, this is what will work for you. And tell them this is what your understanding is. So, and a lot of patients, I have patients who are scared that they have cancer. They would do anything. And I tell them this is not cancer most of the times. There's been about at least 2 instances in the last 5-7 years that I've been wrong. One patient has had salivary. I want to say it was a tumor. It ended up being a benign tumor, but I missed it. Not for too long, but I missed it for a couple of weeks. And then second was a joint problem, which I only saw the patient one time. So, but that patient had some joint tumor. It takes time, but always pay attention to differential diagnosis. and try to document your finding about diagnosis and treatment. All right. Before you, I always tell my residents, before you think of oral appliance, think of what can go wrong. Think what not to do before you think of what to do. And I have this open dialogue with patients before I start oral appliances. Can their teeth shift? What kind of design is it? Why? How long do they have to wear it? You've got to think of all practical aspects of this. Can things get worse? I always tell patients about 10-15% of my patients get worse with oral appliance, not because the appliance was done wrong. They just were not a right fit for that particular design. You have to tweak it or change it. So think of what what cons could there be. Informed consent is very important. Occlusal changes, especially in young people, up to, I would say about up to 25 years of age, and we'll talk about that. Things move very quickly, okay? This is just my observation. It's occlusal changes happen more in people who have history of orthodontics compared to people who have not. I always tell patients, a mouth guard is not supposed to change things, cause any pain in your jaw, head, and neck region. If anything happens, you stop it and reach out to me. So I use a fair amount of chairside appliances, like a quick jig or NTI or quick splints. So I'm not a big fan of over-the-counter appliances, but there's definitely value, especially in acute scenarios. Quick splint is a very easy appliance to fabricate. Takes about a minute or two. You can make it on maxillary or mandibular. Before quick splint was there, I used to make NTIs. I usually use these for like 10 days. The problem with NTIs, which is nociceptive, I always have to look at it, trigeminal inhibition tension suppression system. It's a very fancy name, has no clear data that that's really what it's doing, but it's effective. It's FDA approved, although FDA looks at safety. They don't look at efficacy. So it's a safe device, although there's about 7 to 15 people who have aspirated this. It went into their lungs. 7 to 15 out of how many? Potentially hundreds and hundreds of thousands, a very small number, but the risk is real. So, and in my career, I've done lots of these. Never had a problem, but I do explain the risk to patients. So, this is kind of a quick, and now the new NTIs are a little bigger than the old ones, so the risk is even lower, but still. I had a resident with an NTI once where they kind of didn't remove it in time and it was locked and we had to section off the NTI, so that's a cumbersome risk with NTIs. I've seen occlusal changes with NTIs. Quick splints, they just break off in 2 to 3 weeks, so you have a lot more control in that sense. At times, if the teeth are really small, quick splints, the retention is not as good. So that's the problem there. I use these transitional appliances when somebody cannot open, they are in acute pain, they just cannot tolerate something. I just had a patient who was getting periodontal surgery in like 2 to 3 weeks, and she was like, should I really get an appliance? I was like, let's do this. So in temporary situations, I use retainers very commonly as oral appliances. My go-to retainers are really about 1.5 to 2 millimeter oral Essex retainers, and they work great. I use them especially for young patients, a teenager, early 20s. At times, I ask the patients to use them alternatively. Do a maxillary one night, mandibular one night. What am I trying to do? I'm trying to just confuse their brain. Somehow change the sensory input. Is there any evidence? Zero evidence. Like, not one study has looked at using retainers as oral appliances for temporomandibular disorders, just my personal experience. And about 2 weeks ago, I have a 13-year-old patient comes in. It's like, mom says, he's been having jaw pain for like now a few weeks. We went to our pediatric dentist and she made him retainers, thick retainers. They didn't do anything. And I'm like, really? That's what I do, I was thinking. So I examined him. He has muscle pain. I was like, wonder why it didn't work. I was thinking, okay. And then I asked the patient, mom, I was like, does he complain about the retainers? She was like, no, he thinks it's fine. Reached out to the pediatric dentist who I know. She was like, yeah, I have had a bunch of patients where you did just that and it worked every single time. I was like, okay. So what I do is, I spend 45 minutes, I explain them there's nothing really going on. And I just asked them to do it alternate days and do warm compresses, 12, 15 minutes a day, and just gentle massages on the masseters. 3 days later, mom calls, pain has been zero. I was like, okay, I want a feedback in a month. Same thing, no pain. So what happened? I think the whole role of empathy, I really think the pediatric dentist, who is wonderful, my kids used to go there. They make appliances, they don't explain what to do with them, what can go wrong, the mechanism. Education has a big therapeutic value. Without that, it's a piece of plastic. You can really make it something. So I found it interesting that a couple of my referrals are now doing exactly what I was doing, which is interesting. So this is my go-to appliance. Not necessarily in this format. At times I make it processed acrylic, but at times if a patient has a large tongue, I have nothing covering the lingual area and extend it a little longer in the buccal area. I have the lab put ball clasp. So you have to tweak the design according to the anatomy. Make it comfortable to the patient. Ask them where they feel discomfort. If they say their lips feel too full with an appliance, remove the labial flange. If they feel they have trouble breathing, make it almost remove the palate. So, and stabilization appliances work for muscle pain, joint pain. There's really good data that they are quite benign. Occlusal changes don't happen commonly. And that's how I start most of the times. And if it doesn't work, I go to repositioning appliance. My patient pool is complex, so a lot of times stabilization appliance don't work. They come back in 2 weeks. I switch them to a repositioning appliance, and I charge a fair amount, a high fee for an appliance. So I tell them if I have to switch appliance, it's not going to cost extra. So I switch to a repositioning appliance for like 2 weeks. If it's working, continue that for another 4 weeks and switch to stabilization appliance. So long term, I'm really doing stabilization appliances. But repositioning appliance, I only found this paper in Cranio, which found some benefit with a repositioning appliance. I think it's a great tool to have. Most of the repositioning appliances have a a palatal ramp, but you could have a repositioning appliance with a buccal flange in the mandibular. So there's a few different ways to do that. Quite effective. You can have your lab you can go to a sleep lab and ask them, I don't need a sleep apnea appliance, I just want the jaw to be a little forward, and they'll help you design something. This is a quick repositioning appliance I did for, it's like a 78-year-old person on the right. And same appointment, I actually made that. And long term, I gave them a stabilization appliance. I told them, he came from like 100 miles away. I was like, once you're doing better, you're going to switch to a lower appliance, and then I'd like to see you in like 2 months. So to kind of consolidate his visits. So, all right, we're good on time, good. So some of the my personal opinions. Comfort is key. If it's too tight, or if it's encroaching your airway, if it's too bulky, if it's somebody who has really bulky cheeks, you don't want anything covering that area. Comfort is key. Second, there's no data to show a particular appliance works better than the other. You can have maxillary appliance, mandibular appliance. There's 1 or 2 studies which show that soft appliances can make things worse. Occlusal changes happen very quickly with soft appliances because they don't retain teeth. So there is some issues with soft appliances, but I have about a couple of times every 3 months, I have patients who don't tolerate a hard appliance. I go to a thick, soft appliance, and they're doing better. There's value in it. Don't have a strict protocol. Be flexible. If you spend a couple of days with me, you'll see 10 patients with very different designs. I usually come with a diagnosis, a plan, oral appliance, and then I ask the patient where they feel discomfort, if they have a strong gag reflex. So when they have symptoms, if somebody says they have symptoms, they wake up great, no symptoms, but as the day goes by, they start having pain. I ask them to use a lower appliance only at daytime, usually for 1 to 2 hours. So plan your treatment according to when the symptoms are most prominent, because it could be just, even though that patient could have a chronic process, it may still have a very peripheral mechanism, and you may be able to limit it by those 2-3 hours of daytime mouthguard use. I rarely use partial coverage appliances. If I do, I usually have a labial bow, either only canine to canine or even a full arch labial bow, so at least they are not shifting. Over the years, previously I used to use more partial coverage appliances, and even in my patients I had a couple of occlusal changes. So I don't like partial coverage appliances, but it's just my opinion. I was looking up on our friend Google, and look at the chart of how much the oral appliance use has gone up. And this is real. There's some data to show it's really common modality employed by dentists. Is it reasonable? What do you think? Before I'll end like 2 minutes. Is it a good treatment modality? I think depending on the condition. So if somebody is grinding their teeth where they're not breaking teeth, they really don't have headaches, they may or may not be a good candidate for an oral appliance. And things go wrong. We really don't have good data how many of patients who go for oral appliance have side effects. Because it's a removable device, they have discomfort, they remove it, the data is just not collected. If I had to guess, I would say 10, 15, 20% of patients have side effects, occlusal changes, pain, trouble breathing. There's a couple of papers showing their sleep apnea gets worse. So certain designs definitely make sleep apnea worse. And then the big one, some people actually grind more with an oral appliance. So always think of, is it really optimum treatment or not? I've had patients where I just discontinue their oral appliance and that's all they needed. Which, so I'll end with that patient. So Jian is a 24, 25-year-old patient, seeing a couple of orofacial pain practitioners, couple of dentists. She's gone through 4 appliances in the last 3 years. When I'm seeing her, she's touching canine, premolar, canine, and that's it. She is clearly, mandible is anteriorly positioned. I'm thinking, what am I going to do? So she has a repositioning appliance. I'm like, listen, and she has this pain, constant pain, muscle relaxant. Actually, the last person she saw, muscle relaxant helped her, but she doesn't like how it made her feel. And she was like, I was like, my diagnosis is you have muscle pain. So muscle relaxant was the right treatment approach. She's like, I did it for 30 days. The day I don't take it, I have a lot more pain. The day I take it, I have less pain. I don't think it's valuable. It goes down to goal of treatment, what Emily just mentioned. You have a structured physical therapy for 4-6 weeks. There should be improved outcome, which she was not seeing. I was like, okay. I was like, listen, the way your bite looks, I don't know what to do with, and I'm very candid with patients. I tell them how I feel. So I'm conflicted with, do I do an oral appliance to force your jaw in a better position, or do I? So I was like, let's do this for like 3-4 weeks. Let's not discontinue your appliance. She's like, it feels good when I have it. I was like, it doesn't matter. Just because you feel good, but your pain is not better, it's just helping your psyche rather than your physical pain. She's like, okay. She's like, she goes home, stop using it. 3 days later, get an email. I'm having a little trouble eating. I'm like, I don't think you need to come in. Let's give it another 3-4 days. 4 days later, she emails me. Eating got a little better. I'm still eating mushy foods. Fast forward, now I'm going almost a year later. In a year, I've seen her like 3 times, very kind of okay, so not with a clear schedule. One time she had a really severe pain. We did some trigger point injections. And if you look at her bite, she's touching pretty much all her back teeth. Her quality of life is better. The biggest thing I did, not the trigger point injection, I just stopped using the appliance. I just asked her not, because clearly it wasn't really putting the jaw in a better position, which she was told it does. So I suspect if I did a different appliance, I would have made her worse. Why do I say that? Because I've done that and suffered. All right. Questions? Emily, you want to come on?
Well, I think we're going to do
the panel. All, okay.
Yeah.
Thank you all. So the question is, there's a lot of patients who have significant atresia where the endodontist at times suspects a vertical fracture. Is that a good candidate for a splint? Is that the question? Okay. I think it's a very, as soon as somebody has chipped teeth, clinically I always find if there's extremely sharp edges, that's indicative of recent bruxism. There's no clear data. A sleep study can really show us, but otherwise, so if, so in history, I always say, in the last 6-12 months, have you had to do a fair amount of dentistry? And even if they say they needed, they keep on having pockets, or of course, if they have root canal treatments or fillings, it's usually, I think that's a good indication for an oral appliance. At times, if you see diffuse wear, I usually do a flat plane top and a flat plane bottom. Almost like rims, but really flat. So my goal is to redistribute forces, and you have top and bottom, so you're really splitting the whole, you're distributing the forces diffusely. And you can have the lab make it very thin, so it's not cumbersome to the patient.
What do you think about splints designed with the canine guide?
So the question is, what do I think of splints designed with a canine guidance? So I'll give a two-pronged response. So if you look at evidence, there's not one study which show that they are better than any other. So canine guidance or a centric relation, there's zero data. My personal experience, in a small subset of patients, they definitely work better. I usually go with a canine guidance with patients who have ear symptoms, and I'm finding some benefit, like more benefit than not. So anytime patients comes in with like ear stuffiness, ear pain, even ear ringing is more an outlier. I don't have good predictability. A lot of patients don't really get better. But ear stuffiness, ear pain, I feel a lot of patients do get better with like a canine guidance, appliance with a canine guidance. But mind you, all my patients get a pretty robust self-care kind of program with it. I usually spend 20-30 minutes talking about stretching, nutrition, sleep. So some of the results are a little bit difficult to interpret what's working. That's kind of, but I really like it when it comes to ear symptoms.
So I'm going to also jump in and say, as a PT in a practice where dentists are usually seeing my patients first, and then they come to me, the questions that the patients have that they're always a little too scared to ask the specialist is really, do I really need this? Will this work? Will this not? And I really appreciated what you said, Dr. Chandwani, about basically the splint is a piece of plastic. And what you do with it, whether it's the relaxation, the self-care, really understanding that you can't just expect to put that piece of plastic in your mouth and it's going to do all of these magical things. And I think from that dentist perspective, when you are talking through and clearly outlining those expectations with your patients, that's one of the best predictors of success. And not even, you don't promise them that it's going to work, but basically saying, this is what you can make of it, and here's why I'm choosing it.
And I go a step further. So in my kind of business model, if it's a patient who is grinding their teeth, and when I'm discussing fee, I usually say, we do a mouth guard for bruxism, we do a mouth guard for pain. This is going to be $500, this is going to be $950, this is going to be $1,850. And they're always like, can I have my dentist make it? I was like, sure. And then most of them take a step back. Wait, 400 or 500? I'm like, this You get an appliance, there's no office time, it's going to be comfortable, I'm not going to spend time. It takes me literally, the lab makes it, I spend $50, $75, I don't spend any time on it. If it doesn't work, there's no kind of follow-up. It's as good as buying an over-the-counter, but a little better compared to an oral appliance where I'm putting canine guidance, I'm mounting it, I'm spending 2 hours, it's going to cost a lot more. Same mentality, if you're doing dentistry, a temporary crown versus a ceramic crown, you have tiers of fees, right? That's how I put, even for splints, the fees. And patients appreciate it. I was scared when I first started doing it a couple of years ago, and patients get it. And the other thing is, patients don't go to other practices, get an appliance, and comes back. Usually, if they do it, I'm like, that's fine, you can get an appliance from your dentist. Every visit is going to be an office visit, $395, $495, based on time, and a splint turns out to be more expensive in that scenario. So you always want to think of balancing the business model and clinical model, all like.
I actually have a question for Dr. Bugero. And keep thinking of additional questions to ask everyone too. I'm anticipating perhaps everybody in this room hearing your presentation thinking, this is fantastic, this is phenomenal, and then maybe thinking, how in the world do I tell my patients that I think they need to see a psychologist without them hearing stigma and getting defensive? Do you have any suggestions of wording and ways to bring it up to people to introduce that concept?
Yeah, absolutely. So what I always, whenever we see a patient is I always, over the years I've kind of have my introductory speech and I say, we know that when patients have had pain as long as you had, it's not just the pain, but it's also the impact on life. And we know of some strategies that can help improve quality of life, in addition to maybe doing something for your pain, but these approaches will help you get some quality of life back, because right now the pain is really taking over for a lot of your life, and we have some techniques that are specifically addressed for that. That's usually what I say. There's different versions of that same message, but I always try to frame it on the outcome, which is like, let's see if we can make your life better with these techniques that we've developed over the time for doing that.
Can I add one?
Yeah, please.
So, when I'm taking a history, and this goes for physical therapy, I have even resistance for physical therapy also,
Sure.
and side. So when I'm asking them about if they exercise and if they have mobility issues, trouble eating, during the history, I almost sow the seed. I'm like, listen, your jaw should be moving better. You should be able to eat carrots and almonds. That's the joint mobility issues. Just remind me if I forget when we talk about, once we know the diagnosis, when we talk about how to best treat it. And then when I'm talking about sleep, trouble falling asleep, trouble staying asleep, as soon as they say, oh, I have trouble staying asleep, I wake up in the middle of the night and I'm up for like 45 minutes to an hour, I tell them that's usually a sign of depression or some mood disorder. I always find it's challenging when I'm treating a physical problem without the help of a psych person. So my history is more a dialogue, thinking out loud as to what are the different kind of, and same goes with an antidepressant for pain. I'm thinking of treatment and I'm thinking with the patient. And if the patient has resistance, they'll express it more when you're kind of laying it out during your history.
And Dr. Peck, do you have any additional suggestions or strategies for connecting with patients on these topics?
Yeah, I mean, I think we've kind of hit most of the key elements already, but just again, emphasizing with patients the biopsychosocial model that's the most evidence-based as opposed to the biomedical model where it's that fix-it approach. In residency, we were so fortunate to have a health psychologist as part of the team. Now, in private practice, we don't have that, but I like to emphasize to patients that, the fact that I'm recommending a psychologist to you is not because I think you're crazy, it's because I know it helps, and you can use some of the terminology or the verbiage that Dr. Bagero used as well. But the buy-in generally, I think if you approach it with compassion, is generally pretty positive, because these patients who you're having that conversation with, they've been suffering. It's not a surprise to them. So they're really looking to you for answers at this point, and that's a very evidence-based answer.
Question, yes.
I do have a question for you that I have, just because this is so relevant. I just actually spoke to a patient over the weekend. She is going through a hard time right now. She's going through a very stressful period.
The benefit of
Sure.
anybody
Thanks.
online listening.
Yeah, so I have a patient who's going through a stressful period, and she primarily uses religion. Because I had actually asked her before, what I typically do is I ask patients, have you considered talk therapy, instead of saying you need a therapist? Because when you ask them first and then you talk to them about, I understand you're going through these difficult circumstances, this could be something that can get you through this hard time, rather than saying you have this problem, this diagnosis, you need to see a therapist. So that was just an approach that I had that came off softer. But I had a question for you. I was wondering what you would recommend to help facilitate the physical therapy referral. Are there certain diagnostics that you would want us to send with the patient?
So, yes and no. I would say there aren't any diagnostics that are specifically required, aside from just, here's your diagnosis, here's what I found. If there are any things that you've seen say you've taken a Panorex scan, and you can say, we've ruled out dental pathology, but they're convinced that there's a tooth fracture. or some of those things as you're going through your assessment, because we know the non-odontogenic tooth pain, that patients will be absolutely convinced they need a root canal or they need some sort of interventions. And then if they've gone through, I think it was Dr. Bender who was talking about it yesterday, saying, please don't ever try these invasive things, especially if they find out it doesn't work. So sometimes having those pieces assessed first can be really helpful, because if we're trying to talk about muscle pain and they say, but you know what, I really still think it could be a tooth, and we didn't actually go through all of that at that first assessment, then automatically there's less buy-in, because they are still convinced that it's something else, and they're kind of like, I don't really know if I believe you. So that piece is definitely helpful to assess through and see if there's the tooth pathology.
I'm wondering specifically for migraine patients.
Mhm.
I recently had somebody that was actually getting more migraines triggered from the physical therapy.
Mhm.
So
Yeah, she was just saying a migraine patient, they were getting migraines triggered by physical therapy. And actually, the pre-conference course yesterday that was sponsored by the physical therapy group, I jumped into the very end, and he was talking about that. And again, I said before, PTs are not always as good at understanding neuropathic pain. And I would say absolutely that convergence, the overlap of migraines and the nervous system, and if you have a nerve component that's driving your pain and we're trying to treat it using these musculoskeletal types of interventions, absolutely that is going to flare that up too. So if there's any components that you know of already with neuropathic pain, if you know that there's some trigeminal neuralgia or a migraine diagnosis, just sharing that, saying, I think that there could be a neuropathic component that might be overlapping. But that doesn't mean you can't do PT. The PT just needs to understand then, okay, I'm not going to jump in and do XYZ. I'm going to, put my pain classification hat on and understand I have to use different interventions to appropriately treat this patient so that I don't go in. PTs have a reputation, I think, in my word cloud, I think somebody said pain mongers. And sure, after a knee replacement surgery, yeah, PTs are the ones telling you have to get up and walk 2 hours after you come out of major surgery. And when it comes to treating orofacial pain, I hate the no pain, no gain approach, because much of the time their systems have already adapted to understand that pain is that red flag warning system, whether it's an appropriate response or not. Their body is adapted to pain in protective ways, and sometimes the more you trigger that pain, the more they're gonna pull back, so, yeah. Other questions?
What's the difference between dry needling and acupuncture?
Okay, what's the difference between dry needling and acupuncture? I will talk about dry needling, and I'm gonna refer to Dr. Chandwani about the acupuncture, but dry needling is, it's probably an oversimplification, but I think of it as trigger point release, but with your needle. And you're finding that trigger point, and you can either lightly piston, or you can do, there's a twisting technique, but you're specifically targeting that musculoskeletal trigger point. And there are many other dry needling specialists who understand more, who can probably talk a little bit more about some of those purposes, but to me, I think that's one of the primary differences with acupuncture.
So, yeah, so dry needling is really, we are needling in the painful area. So it could be muscle, tendon, and areas that are not easy to manipulate manually. So lateral pterygoid, or really isolating just the tendon of the temporalis. So manually manipulating it without traumatizing it is actually harder. So putting a 31 gauge needle is extremely seamless. It doesn't even break a capillary. So that's dry needling, like she said. It's like a deep tissue release. Doesn't mean it doesn't, it works quite well. So I do it fair bit. And then acupuncture, the philosophy is we are injecting 30, 40 needles on different meridians with the idea that it will improve the chi or the energy channels throughout the body. So the philosophy is different, and the point insertion is, points that we insert are a lot more.
And I sometimes will also explain to people with acupuncture, you put in the stimulus, and then it's like you're letting the body do its work to respond. Whereas dry needling is a little more that piece that
So,
the therapist is doing.
I find even dry needling, I do leave the needles in for 10, 15 minutes, 10 minutes, I stimulate it, and I'm like, can we leave the needle in for a few minutes? Are you in a rush? Patient's like, okay, I want you to stick around for a little bit. I find it works better.
Yeah, and also I know there's a poster about a dry needling case, and they used stimulation with it too, so. Okay, and there was one more question. Oh, but I think she just left, shoot. Question back there.
So, question regarding the last patient that you shared,
Mm-hmm.
mandibular anterior positioning, the anterior context. Do you feel like if there had been a referral to a physical therapist, the speed to recovery would have been faster? Or do you feel like it was just time?
Are you talking about Dr. Chandwani's last example?
I think it was time. I kind of missed, I didn't actually share it. She did do a fair amount of physical therapy before I saw her. I think the appliance was probably interrupted any kind of physical medicine benefit also. So that's kind of my thinking. We'll never know.
Yeah. Yeah, and there are, like, I also appreciate how you say, there are times when our treatments don't work. I mean, I picked 3 great cases that explained my points, but not all the time.
And whenever I have over the years, I've heard lectures where we are in such a field where speakers talk about, oh, this works so great. But if you look at really medicine and temporomandibular disorders, the efficacy of most intervention is in the 60 percentile. So if you're not getting treatment failures, I feel at times if I'm really on a slow day, I often go to cases which I saw 5 years ago and saw how many really got better 2 years later. And around 20% really did not get better. So 60 to 80% is success rate. If 15-20% patients are not failing, you don't see it, you're just missing them. They just fired you and kind of moved along. So that's kind of the reality. I actually tell this to patients during the first visit. Efficacy of oral appliances is 60 to 80%. And we'll talk a little bit more when we do injections. But I kind of frame it up, even with medications, with long-acting, I also happen to like meloxicam and naproxen, and I tell them, they work 60-65% of the times. If they don't work in 3-4 days, just let me know and we'll switch the medication. Setting expectations, I really think it improves your outcome, even short-term and long-term outcome.
All right, I mean, we technically have 2 minutes left. Are there any last questions before we break for lunch?
Any experience with COX-2 NSAID?
Yeah, meloxicam primarily is the one that I'll use. It's preferential towards COX-2. So
That's celecoxib.
celecoxib is another one. I personally I like Mobic, but yeah, you could use either one, and just got to kind of monitor for cardiovascular history in those patients in particular. But they generally work. I've found they seem to work a little bit better, and they're pretty well tolerated as long as those patients don't have cardiovascular issues.
I agree. I have the same experience.
And I have patients ask a lot, well, I'm on a muscle relaxant, but I still have muscle pain, so what's going on there? And I look at muscle relaxants as being a tool that helps the physical therapy or the splint or other types of interventions work better. Because to have the amount of muscle relaxant in your system to help a certain trigger point decrease probably would not be safe because it's systemic. So it's going, and so we'll talk about that piece of it and say it definitely takes that edge off to help improve those outcomes and to help the physical therapy work better. Oh, and you came back. Did you have a question before? I'm so sorry. Yes, could we answer your question now?
I had a few. One of them was actually about the isokinetic resistance, that study.
Yes.
I guess I could just look up the study, but the patients in that study, they obviously had a click.
Mm-hmm.
Did they have, were they also filtered? Did they only have a click or?
Right. So it was young. I forget exactly how they identified that, but it was people in their late teens, early 20s. So I think the idea is their system is a little bit more adaptable. It was a unilateral, painless click. So very recent onset too. So that it's not like they'd been having a click for 6 years or something along those lines, but an early enough click where I think they had the thought that they could continue to modify how the muscles were interacting and possibly even help to adapt the disc further. But essentially what it is, you'll say you're clicking on the left side and then you add some resistance to the opposite side. So when you are putting resistance on the right side, that left lateral pterygoid should be activating and then that right one should be disengaging so that you can actually move to the side. But by having to stabilize a little bit against the finger and still do this controlled slow movement off to the side, it allows you to have more control about how it's moving, so it's not just going to click past the disc if you have, say, a slight medial displacement. But by teaching people how to move within a stabilized range without having to reduce or not, go back to being non-reducing, you can actually help to train and coordinate those muscles to function in that stabilized range. And so by adding that small amount of isokinetic resistance, you can slowly increase the range over time, and the jaw has learned how to move in that range without having to keep reducing back into place. Now, this is an old study, and I've had plenty of older people do the same kind of thing and get some good results in terms of stabilizing. So, but to my knowledge, they didn't filter beyond, what I said, the unilateral, painless, more acute onset click.
Another question for you. If a patient's diagnosed with myositis, or how does the PT manage that, or do we get PT involved?
Yeah, so myositis, if you have some sort of an inflammatory component, you certainly can if you have medication management that you want to do, absolutely. But with any kind of problem with the muscles, the system is going to be guarding, and you're going to be moving differently. So I wouldn't say if you have an infection or inflammation, by protecting or changing how you move, you can certainly manage, I maybe wouldn't, again, going back to the modality question, ultrasound, some of these things that are contraindicated if you have an active infection or something like that. But most PTs aren't using those anymore. So I think, I don't know, anybody else have any
So for
contributions?
myositis, I'd say the most typical that we'll see is going to be like a patient who had an IAN and their medial pterygoid goes into spasm afterwards. They maybe a week later they say all of a sudden I just can't open my mouth past 15 millimeters. My protocol is going to be very similar to like a typical patient, where physical therapy definitely. We know that those challenges are generally self-mitigating, so it can take a month or two in some cases. It could go away in a week, but yeah, it's going to be analgesics, anti-inflammatories, maybe a muscle relaxant. Especially if there's no history of TMD issues. The differential is going to have like a mechanical disc issue lower on down the list. So you just have to kind of educate the patient, help them through it. But yeah, I'm definitely getting that patient into PT.
Yeah, and it's another example of where you're going to want to mitigate how much pressure you're using. Like the question before. If you have someone with myositis, they're not necessarily going to respond really well to deep trigger point release. So teaching them how to calm their own system helps facilitate, and then like I use controlled rotation essentially. Like I'll tell people, if you sprain your wrist or your ankle and you're going to pump your wrist or pump your ankle, you're pumping your jaw. You need that movement to get that circulation. But yeah, absolutely there are indications, and that's where it's helpful to communicate with a PT as well, to say, this person is a little more irritable at this point. Especially the deep intraoral muscles are incredibly tender and sensitive. So, but yeah, absolutely lots of things that PTs will do.
So you do want to work it,
Yes,
you don't want to just rest.
right. Rest will probably encourage development of some maladaptive strategies, in fact. So you still need to use the muscle, you're just going to not push it to overwork. And that's, again, where there's the fear avoidance piece. If somebody is terrified to open their jaw after they've had dental work, then their jaw's not going to think they're supposed to open. So we have to find that balance to help them move in a way that's helpful and protective, as opposed to irritating and inflammatory. Okay, so I believe we're back at 1:45. Does that sound right for everybody?